Welcome everybody. Thank you very much for joining this Zoom meeting this afternoon. I would like to introduce myself first. Some of you know me, some of you don't. So I'm Dr. Vijayabhaskar. I did my BDS from Chennai and then went to the UK in 1998. I was there doing some maxillofacial jobs. Then I got my fellowship from the Royal College of Surgeons, England in 2002. Then I joined general practice and I worked in general practice, had my own practice there. And finally, 2017, I returned to India. I relocated completely and I have a practice in KPHP. That's about me. That's my introduction. Um, Basically, first of all, I would like to say why we decided to have this meeting. One of my close relatives and his daughter, both of them, they tested positive for COVID. And basically, I came to know in the evening, and we were suddenly we realized that one of them is feeling a little bit of shortness of breath. So we tried to contact several doctors in Hyderabad and several hospitals, and we could not get a hospital bed. And shortness of breath is something that needs admission, and we were really panicking at that time. So we decided to speak to somebody, and they did a video consultation, and they suggested that this is not actually shortness of breath, it's actually due to some blocked nose or something like that. So the panic was a little bit reduced, but we were still looking for a hospital bed. So next day morning, that night, I spoke to quite a few friends of mine back in the UK and in India as well. And I spoke to particularly to Dr. Srikanth Chukkambotla, who is the speaker today, who is our esteemed speaker today. So I got a few tips from several people, and I had to accept this as something that's inevitable, wherein someone dear to me is having COVID infection, and I had to support them somehow. So I jotted down all the tips from these people. Next day morning, I bought a few medication, and I bought a few medication. I got my oxygen cylinder, pulse oximeter, N95 masks, and several other things. And just so that we have a pictorial thing, I'll just share that with you. Where is it? Share screen. So obviously, this is not something I'm doing. Dr. Srikanth will be giving the detailed presentation, but I'm giving the background for this. So I bought the pulse oximeter, I bought the oxygen cylinder, I bought a few medication there, and Rivaroxaban, which few other things we bought and kept ready. And that is a prone position, which is very essential. Again, I will leave Dr. Srikanth to talk about this. Basically, we had this situation, and I got all this ready, and luckily they got a bed in Kim's Hospital. They were admitted for 5 days, and they got discharged. Once they were discharged, I delivered the oxygen cylinder to their house. Luckily, theirs was a mild case. They did not use this oxygen cylinder, dexamethasone or Rivaroxaban also. They were given subcutaneous heparin in the hospital for 5 days, especially the senior person. So this is the background. So I was discussing with Shekhar Reddy, and he said, why not do one Zoom meeting with your friend for this, for all our dental fraternity colleagues, because we are also at high risk with COVID infection. I thought that was a wonderful suggestion, and I asked Dr. Srikanth, and he kindly agreed to do this. I just need to welcome Dr. Srikanth. Just one moment, I'll find him. He's there, where I need to unmute him. Dr. Srikanth, can you unmute yourself? Dr. Srikanth? Yeah. Okay, great. So I would like to just quickly introduce Dr. Srikanth. He's a esteemed friend of mine from Preston. where I used to live in the UK. And he's a consultant in anesthesia and critical care. He's also director for research for COVID recovery trial in the East Lancashire region. He himself, he's a COVID warrior in two senses. One, he has saved several lives in the intensive care, being a COVID warrior doctor. And also, he himself contracted the disease, and it was fairly moderate or severe. And he's been very brave and courageous to fight it at home. And he came out successfully with his whole family, actually. And he is now actually back in the wards and back in the ICU unit helping patients. So over to you, Srikanth. Thank you very much for joining us.
Good morning.
One more thing, one last thing before Srikanth, you said, just wanted to give a disclaimer that this is not like a recommendation to not go for a medical help. So long as you have medical help, certainly go for medical help and take the medical help. But in case of dire necessity where it is not possible, this meeting, this talk and this presentation will certainly help. And my close relatives who got it, they had enormous benefit from the suggestions from this meeting, from this discussion that I had with Dr. Srikanth. Over to you, Srikanth.
Thanks, Vijay. Good morning and good afternoon, all of you who joined the meeting. First of all, let me introduce myself. I'm Dr. Srikanth Chukkambotla. I've been a consultant in anesthesia and critical care for nearly 12 years now. I work in Royal Blackburn Hospital, which is closer to Preston. It's called East Lancashire NHS Hospital Trust. So clinical background wise, I was a student at Usmania Medical College. I did my MD anesthesia in Usmania Medical College, and then came to do FRCA in UK in 2001. And then since then, I've been working in NHS. In terms of research background, I've been doing clinical research within the critical care for the last at least 7 to 8 years. I've been a research lead in the department, and now I'm a research director for the entire trust. As Vijay mentioned, I'm also a principal investigator for the recovery trial. I'm sure you must have gathered the headline news with especially about the hydroxychloroquine and as well as the dexamethasone. The recovery trial could manage to sort of give a sense of direction to medical community, which drugs are useful, which drugs are not useful as well. I want to thank Vijay to give me this opportunity to talk to you all. And I just want to make it clear, this is a sort of fairly informal meeting just to share my experience as ICU consultant, as well as how we, as a family, we came out of it. And just to give you all a few tips, just in case if it is a mild disease and mild to moderate disease, and this is predominantly for low risk group people who can manage at home. And so don't take it as this is an alternative to visit to doctor or medical advice. Obviously, this is coming from medical experience, but this is fairly informal chat. The first 10 minutes, I'm just going to talk about my experience. I just want to run past what happened in the last, 3 to 4 months here in UK with my life and my family life, and how we had the COVID. And at the end of that, I'll just put a PowerPoint presentation just to run past again the similar topics. And then at the end, we would like to give a chance for everybody if they want to ask any questions. So there'll be a question and answer session at the end. Obviously, I'm sure you must have all sort of started hearing about COVID at the sort of beginning of January 2020. And that's when I started paying some attention, especially when Wuhan city started going in lockdown. Until then, even I didn't pay much attention. But once they said, oh, we're going to lock down a city of 11 to 13 million population, that suddenly started grabbing the attention of entire world. And that's the first time sort of I started paying attention to the COVID problem and its potential to become pandemic. The reason I started paying attention was that obviously as a ICU consultant, I need to know. And then second thing was at that time, I had a planned trip to India to attend a wedding. But I just want to be aware that I was focusing how this could spread so fast. And then we ended up canceling our family visit to India back in second week of February, wherein most of the world probably barely paying any attention. And if you remember, that was in February. I think Donald Trump came to India, and the whole activity in terms of country politics, everything was at a different level. And then in March, at the beginning of March, here in NHS, the activities sort of suddenly started paying a little bit more attention to COVID. And between Feb and March, the cases, they used to manage to identify isolated cases and then contact tracing and isolate people and isolate the contacts. But once we entered into March, it was a different scenario. All the hospitals were asked to start increasing their capacity. So within my hospital, we were asked to increase our critical care capacity by 7 times. So there were plans in place to stop all the elective activity and then focus on purely COVID-related clinical activity. So the entire organization was going restructuring, reorganization, reallocation of resources in terms of medical, nursing staff and equipment, everything else. So obviously I was part of all that planning and restructuring, and it was so drastic. We just had one meeting, an emergency meeting, and then next day onwards, all our shifts and on-call patterns were changed. In the past, we used to say like 2 consultants on any given day for critical care. One used to do a 24-hour on-call shift, where after that meeting, we ended up having to go to 9-hour shifts and 6 to 8 consultants at any shift in the hospital. So you could see the challenges in terms of suddenly changing the work pattern, lifestyle. We had to drop all the other activity. But the most important thing is, because we knew that this is a new disease, and by the time we had a sort of information coming through China as well as the Italian experience, we knew it is a new disease. We knew it is just not another flu. We knew it is just not going to be another viral infection. And watching what was going on in the northern Italy, we knew hospitals could be overwhelmed, and you could see like hundreds of deaths on any given day. So whole entire NHS was gearing up for possible mayhem in UK. And personally, my point of view, it was like constantly updating myself. I had to sort of, because there isn't any official information released or official guidelines at that time. So you just go on to Twitter, you just go on to Telegram, and you find wherever you can the information from, and then sort of trying to constantly learn. That was like self-learning. And then obviously colleagues, whatever they used to find, they used to put it on the WhatsApp and emails. And within the NHS, NHS England is the overarching body who used to update professionals, all the healthcare professionals. And again, the guidelines almost kept changing on a weekly basis. So it's a constant challenge to educate yourself and adapt your personal lifestyle as well as the work time and everything. another thing is, I forgot to mention that my wife is a general practitioner. So we, as a couple, we both were at the extreme ends of the healthcare system. She being a general practitioner, seeing patients, unexpected symptoms, unexpected illnesses, wherein I'm exposed in the hospital to sort of suspected or confirmed COVID patients. And we, by sort of second week, third week onwards, in the hospital, we started having a sudden surge of COVID patients. And within my job role as a consultant critical care, my job was based purely in intensive care. So when I said we had to increase the capacity to 7 times, normally we have like 2 big intensive care units, which would take 24 patients, all ventilated beds. And when we increased our capacity, we ended up spilling into 4 other different wards on top of the 2 regular ICUs. So it's a constant anxiety when you're driving to hospital, not knowing exactly how and when you might contract the infection. And then we just started learning what is PPE, how to use the PPE, how best you can protect yourself. It's a constant learning. I'll just give you one example. On the first meeting, the infection control team and said, "Oh, this is your PPE." And when the nurse who is sort of trying to give us a demo, it was like a flimsy plastic gown, and wherein you had a lot of exposure in the back, a lot of exposure to the neck, and the face shield was not introduced at that time because this is right at the beginning. And so we had to challenge them and said, no, this is not good enough. We need to have a right gear, right masks. So that is one simple example. So we had to constantly improve our own safety while concentrating on how best we can provide the patient care. But in terms of home front, because we both are sort of suddenly working hard, long hours, and I got 2 boys. One is 11-year-old, the other one is 15-year-old. And at dinner table, it's a constant discussion. And it's not unusual. We talk about, boys tend to ask, how was your day? And we tend to tell them what's been new and what's been going on. And then obviously they were kind of following the news on BBC now and then and listening to COVID news. So, but we just had to, introduce what is this infection potential for pandemic. Obviously they knew why we ended up canceling the trip to India. So they were also part of the discussion at home. And then there are 2 folds to that discussion at home. While we were educating them, while we were educating ourselves, we also had to sort of prepare ourselves. At one day, we could end up having infection at home. That means it could spread to others at home. What we should do, what we should not do, how to protect or how to sort of spread the infection at home to others. So all these questions were coming to our mind. And so my wife started ordering certain sort of sanitizers and cleaning wipes, including some PPE, because we were struggling to, well, especially their GP practice, they didn't have enough PPE kit and gloves and masks. So she ended up ordering her own masks and her own gloves. And so we started sort of collecting some equipment at home in terms of infection control and prevention point of view. And so the whole sort of shopping and the things should start changing early in the March. And then April comes, a sudden big surge in the hospital. We had 35 patients all in one hospital, spread into 4 different wards. Everybody, well, almost I would say 26 to 28 patients were on full mechanical ventilation. That means sedated, intubated, and at least 1/3 of them or in prone position. So it's a huge workload. And then at the beginning, however fast we were responding in the hospital, going down to A&E, intubating these patients, we had certain sudden deaths. Some people were dying as soon as they came into intensive care. And we had to bear that emotional trauma as well. As a clinician, questioning ourselves, did we react and respond quickly enough? And it's a kind of constant challenging to deal with that emotional turmoil as well. And then I worked through that, nearly 6 to 7 weeks in COVID intensive care unit. And we over a period of time, we developed kind of religious rituals at home, in the sense we used to keep separate sort of clothing to wear hospital, and you keep a separate bag, and whatever you take to hospital or my wife's workplace, we used to, as much as possible, leave it in the car, or it's all kind of paying attention to everything. And we used to straight go to shower and not touch anything, not to give hugs and not to touch the kids. So we had to change the whole sort of behavior patterns. So we thought, we were doing reasonably well and ultra careful in terms of protecting ourselves, and but at the same time trying to pay attention to what's going on around the world and what's going on around in UK. And suddenly, I think around April, with the big surge, the death rate was going up. And then suddenly there was this talk came about mortality among the healthcare professionals. Suddenly started going up. We had sort of, by end of April, we had something like 150 to 180 deaths among the healthcare professionals within UK. And the Guardian newspaper used to run sort of pictures of all these healthcare professionals to pay tribute. A lot of them were young, 36-year-old critical care nurse or 46-year-old sort of general practitioner. So there are lots of different walks of professionals within the healthcare professionals: doctors, nurses, midwives, porters. But the catchy point was the people from ethnic minority background were disproportionately affected in terms of contracting the infection as well as the deaths. So that started sort of raising our levels of anxiety for me and my wife. So we were mentally sort of gearing up. Yes, this is going to come home at some stage. We're going to get affected. And in terms of my own health, I'm 46. I've been running 10K for the last 4 years. So keeping my own fitness. The only medication I used to take was Ramipril, known hypertension, for about 4 or 5 years now. And wherein my wife, reasonably healthy, fit and well, she just takes thyroxine. So with that background, we were kind of started mentally preparing, as well as I said, physical preparation in terms of infection control, sanitizers, PPE kit at home and all that. But the other thing what my wife also did was ordering all this vitamin D, vitamin C, and started taking vitamin D probably from February onwards. And then you might have seen the reports, the initial anxiety about use of Ramipril and people contracting COVID. So I ended up changing my medication to amlodipine from Ramipril. But later on, it kind of proven that it was not necessary. But anyway, moving on to May, suddenly one Saturday weekend, we thought, okay, let's have a nice weekend. by then I ended up doing 2 night shifts on Thursday and Friday. So Saturday, pancakes day, and my wife started pancakes, and we had a nice breakfast session with hugs and kisses. And then sort of suddenly by midday, my wife started sort of complaining vague symptoms of like myalgia, and suddenly started having diarrhea. And then she suddenly felt that she started becoming unwell. Nothing sort of serious, but she knew she was not completely normal. So suddenly she went upstairs to her own bed, well, master bedroom, and then she said, right, I'm isolating. So that's how it started. And then next day morning, we both ended up going for testing. Her test came as positive, wherein my test came as negative. And because it is all going in that direction, she stuck to one room, and she didn't come out of the one bedroom, and wherein me and my kids started living downstairs. And at that time, kids were asymptomatic. I didn't have any symptoms at all. And then we started sort of moving around clothing and certain stuff so that we all could stay together downstairs, wherein wife could stay upstairs. I thought about sort of leaving kids into their own rooms, but 11-year-old was a little bit anxious, especially when we said mom got test positive. He was in tears, so I could not put him in a different room. So we were downstairs, and then after about a couple of days, both boys started having some symptoms. Rishi, who is 15-year-old, suddenly woke up sort of 4 o'clock in the morning, had to go to toilet urgently, and he said that is completely unusual, and so start having some sort of GI symptoms, diarrhea. So he's gone upstairs to his own bedroom, started isolating. And then Ritvik, who is 11-year-old, he was okay the one more day, and then he started having fever. So he's gone into his own room, started isolating. So that's how it started. And then I was supporting them following days. I was cooking and cleaning, and I was living downstairs, taking food and drink upstairs. The point is, we were trying to keep everybody separate from each other so that we kind of decrease our exposure to virus. And then we start talking to friends. Well, from the day one onwards, we told a couple of friends, this is what is happening. And then one of my friend who did the shopping, and we start having like disposable plates and glasses and a lot of sanitizers, wet wipes, sanitizing wipes, and some masks and gloves. The most important bit was I was trying to protect myself as much as possible, wearing a mask when I'm taking food and drinks to upstairs, not staying there, unless I really have to. So our house here in UK was decent size, reasonably big size. So I'm trying to keep away as much as possible. But then wherein my wife started having symptoms on Saturday, and then following Thursday onwards, I started having dry cough, sore throat, and following day, I started having fever as well. So I knew it was coming to me as well. And then I had to go for testing on the following Saturday, and the test came as positive. So now we're all in 4 different rooms, and by the time, but my wife's symptoms were sort of mild to moderate. In that sense, she was able to manage most of the things. So by the time it was, we stopped cooking more or less, and it's the friends who were giving us food. They used to deliver food, their own homemade food, and deliver it doorstep, and then we used to collect it. We still trying to sort of minimize our exposure to each other, and sort of taking medicines. Especially the first 1 week, it was all about fever management, and symptom relief as much as possible. So paracetamol and lots of hydration, good nutrition as much as possible, and then trying to take vitamin C, vitamin D. Things were heading okay. And the other thing I must admit is luckily we had a chest physician or respiratory physician who is one of our close friends who used to call us at least 2 or 3 times a day and video consultation. And so we used to follow his advice as well. Other most important thing is, luckily, because my wife is a GP, they always have a kit, the visiting kit, wherein they have thermometer, pulse oxy, and blood pressure kit. And then we had a separate kit at home, and we end up ordering a pulse oximeter actually to help one of our friends who is a emergency department consultant who had COVID before us. So to help him, we end up buying a pulse oximeter. So we had 2 pulse oximeters, 2, 3 thermometers, and blood pressure machine. So the monitoring is the key bit there. So while we are monitoring ourselves at home, we had this telephone advice from our own GP as well as one of my close friend who is a chest physician. So day 5, I was started on azithromycin. Although we knew at that stage it was purely viral infection, probably I didn't have the secondary bacterial infection. This was mainly to prevent the secondary bacterial infection. I started taking azithromycin. And then from day 7 onwards, my friend introduced the chest physician thought I should start even taking the Comox Cloud, because from day 4, day 5 onwards, my temperature was running at 103, 104. The pattern was most of the daytime I used to be all right, but it was late in the evening it used to start. So that's one of the typical features is you get fever in the evening or sort of midnight. And especially in my case, the temperature was high grade with 103, 104 degrees. And it used to last at least 2 to 3 hours, no matter what I do. And so during those first week, when I was struggling with, which is mainly, I wouldn't say I was struggling, it is mainly high grade temperature. So I was just self-isolating, eating, drinking well, taking all this medication. But the main bit was, if I may share this, no matter however hard I was trying to focus on positive things, it started sort of on and off. I used to lose control. But anyway, what I did was I just stopped reading anything about COVID. I was mainly sort of watching news and watching the sort of old Telugu movies and listening to music. But I was reasonably in a very positive mindset because my oxygen saturations were anywhere above 96, 97%. I was not breathless. There was barely any productive cough. It was occasionally dry cough, but it was mainly the high grade temperature. And then suddenly day 8, I didn't have a great deal of temperature. Day 8 and day 9, and suddenly I started feeling a little bit happy. You know, when I came down, while maintaining social distance, we were spending some time with the kids, and I said, well, looks like I turned around the corner. And then I started texting a couple of friends saying that, you know, looks like I'm out of woods, I'm out of danger. And then suddenly the day 9 night, my wife noticed rather than me, because apparently my respiratory rate started going up while I was watching TV and while I was sleeping. And suddenly, without me realizing, my wife started sort of closely monitoring and observing me. And then suddenly she realized that my respiratory rate went up to 26 per minute. And obviously that sort of caused a bit of anxiety and panic for herself. And then she spoke to one of my consultant colleague who is a intensivist, and then started taking his advice. And so she decided to closely monitor on that night, every 2 hours, every 3 hours, checking my oxygen saturations, which was above 96 all the time. But what she kept also doing was um, asking me to prone. At this point, I just want to go back again and tell you a couple of other things. Right from the day one, as soon as my wife knew that she kind of got the COVID infection, she called this other family who had COVID infection, the emergency department consultant. His wife and child did not get it. He's the only person who got it and got better after about 10 to 12 days. So immediately she was calling them and asking how they managed the things at home. So everybody had their own sort of tips and advices. So quite few things came up from them as well, especially using Mirandar Vinay, what is this called? Kashayam, wherein you use all sort of ingredients um, uh, and to make the kashayam, which must have got some sort of Ayurvedic related medicinal benefits. And then most on top of that, it's the maintaining the hydration bit and how they sort of isolating themselves. And but the other most important bit came up was, I think, the deep breathing exercises, how it helped him, how the prone position helped him. So we kind of picked up a few themes. And my wife, because she had the symptoms early on, she started doing this regimental thing wherein steam inhalation at least 2 times a day, which was helping her sort of taking big deep breathing, and then at the same time followed it by deep breathing exercises, again, which we picked up on sort of various websites and Twitter. The other thing was whenever you feel sort of fatigue or tired, although your oxygen saturations might be normal, but then started using prone position. If it's nighttime, you try as best as possible, try to lie down in prone. But if it is daytime, going about half an hour, 40 minutes, whatever you're doing, if you're watching YouTube or reading a book, but just lying in prone with the pillows supporting under the chest, and just taking big deep breathing while in prone position. And yes, this slide, what Vijay just put on, it's like a swimmer's position basically. Rather than it does help because you got sort of left arm upwards and wherein your right arm is a side by. It does help you to stay in the prone position a bit longer. And so my wife picked up all these things from others and found it useful. She started doing it. And then obviously, as soon as I started having symptoms, I was started doing all these things. Although I was not hypoxic, but just to prevent further problems. And so the day 9 was suddenly started things changing. I became more tachypneic, and then following another 24, 36 hours was very crucial, as I was feeling short of breath, even just taking shower. And I had to have a chair just outside the shower cubicle. It was so bad, really. But it was absolutely close monitoring. We used to have pulse oxy all the time, on and off every hour during those 2 days especially. And we had advice from my intensive care consultant colleague. Basically, those 2-3 days when suddenly my symptoms start getting worse, my wife sort of started charting. She put a table with making a chart with temperature, respiratory rate, heart rate, blood pressure, and then at the same time while observing, keeping an eye on the urine output so that whether I'm dehydrated or not. So the couple of things. One is that close monitoring and charting things was giving us a sense of direction, whether I'm improving or whether I'm deteriorating. Obviously, the respiratory rate sort of gradually started going up, 22, 26, and it came up to like 28, wherein heart rate was constantly above 100, 102, 106. Temperature was about 103, 104 when I was having temperature, but usually around 2 to 3 spikes every day. And just I want to do a little bit of touch base on the hydration at that stage. Because I was having high grade temperature at least about 6 to 8 hours in the day, although I was not sweating. Obviously here it was not particularly hot summer, but you will have that insensible fluid losses and your body is working hard, high rate of metabolism. So we were kept taking, my wife was, obviously her symptoms came down a bit and she was, so she started looking after me by the time, more focusing on me. And so in terms of different forms, water, majjiga or buttermilk, palu, and kashayam, and coconut water. So different forms of fluid used to take at least around 2.5 to 3 liters per day as a compulsion, more or less. And that was very, very important to catch up with your fluids and electrolytes, as well as the main bit is to prevent the acute kidney injury. So then after another sort of 24, because my tachypnea was getting worse, my friends most of them were doctors, and 2 or 3 of them sort of gave me a video call and watching me sort of looking so shattered and tired. They were like, no, you must go to hospital. You must go to hospital. And wherein I was kind of struggling to go to hospital. There are 2 angles to it. One is I personally didn't want to be my own doctor. That is against sort of medical ethics, and you should never treat yourself. You should always take another healthcare professional advice, or you should just go and see your own doctor, which is absolutely understandable. Wherein in my care, all these medicines came either from my GP or private prescriptions with my chest physician. So everything was initiated by others apart from paracetamol. But the problem with me going to hospital was very sort of discouraging for me, in the sense that until then I was holding my positive thought process. No, I'm going to get better. Nothing to worry. Don't focus on any negative thoughts. But once people started sort of saying, no, you should go to hospital, my worry was, once I go there, I get admitted. That means, as per all the hospital protocols, my family won't be able to visit, and I won't be able to see them. And then the precision of care, what I was getting at home in terms of food, nutrition, exercise, a little bit of yoga, I thought I might just lose control on all these micro elements of my own care. But most other important thing is, we are the only family who live here in UK, and we didn't tell our parents and my in-laws and extended family in India, because we didn't want to panic them. We didn't want to sort of scare them without, they won't be able to do anything anyway. So we thought, we will tell them when all the dust settles. So all these different elements was playing on my mind, while most of the time I was trying to focus on the positive stories, because as I said, we had this emergency department consultant who is of my age or slightly younger. He got better in about 10 days, but probably he didn't have COVID pneumonia. Maybe I had it. And then I used to cling on to other stories wherein people got better even after in intensive care. I had one of my own sort of colleague who worked in theater who was intubated but got better within after 4 or 5 days, and he managed to go to the ward and got better and gone home. So consciously, I was putting that effort to concentrate on the positive stories. But at the same time, as I said before, whatever I've seen in intensive care, while I was treating the patient, we had some sudden deaths. We lost the control on what we could do. And then in the mainstream media, I've seen a lot of pictures of young healthcare professionals when they died. All those sort of negative things were coming onto my thought process. So when it came to whether I go to hospital or not, I said to myself, I go to hospital when oxygen saturation start dropping, let's say less than 95, or if the trend is going downwards rather than just as one-off value. And with a little bit of encouragement from my friends and my wife, I ended up going to emergency department with the mainly intention to, doing a chest X-ray as well as all the bloods, at least to know where exactly we are. And, in terms of it will give me a sense of direction, how bad is the problem. So the bloods were done. They were pretty much like typical bloods wherein CRP is elevated. Marginally, I would say more than just 100. It was not pretty sky high. But the fibrinogen levels were 9.5, which is one of the indicators. D-dimers was slightly elevated. But the main thing was the chest X-ray, which was not looking great. It was showing peripheral sort of haziness, which was typical of COVID pneumonia, as well as consolidation patches on the right basis as well as the left. And the emergency department consultant wanted to convince me, saying, no, this is not looking good. You must stay in the hospital, wherein I was absolutely scared to get admitted to hospital, seeing what I've seen within the hospitals. And plus I was more worried about my own family here, because just wife and kids, she was just recovering, and the kids by the time already recovered. So all this sort of psychological factors was playing in my mind. Anyway, there was a discussion between me and my ICU consultant colleague who was on call, and then the ED consultant. And then we all decided that given the level of monitoring that we have, given that I have good care provided by my wife, who is also a doctor, and she was already doing a good job, we thought, let's go home. But at the same time, we'll definitely come back as soon as the oxygen levels start dropping. The other important thing, what they did in emergency department was they checked my SATs at least 4 or 5 times over a period of at least 3 hours. They also checked my oxygen SATs on making me walk. It's like checking your oxygen levels after a certain degree of exercise. Because, well, they made me to walk about 50 yards up and down. And then
చూపించట్లేదు మీటింగ్ ఎక్కడ ఉంది అదేం చూపించట్లేదు
Hello. Yeah, okay. So oxygen saturations, checking on exercise is another important aspect. When you are at rest, your saturations might be normal, but if you are in doubt, if you're thinking you're more tired, you should do about like 50 to 100 meter walking up and down the corridor or up and down the, wherever the steps, then check the oxygen saturation levels. Because if the disease is getting worse, you're more likely your saturations will drop on exercise while they maintain normal levels when you're at rest. So they made me to do a little bit of exercise, walking about 50, 60 meters several times, and my oxygen levels were still 96. So they were happy. Well, they were not happy, but they were fairly satisfied to let me go home. And then on that night, I had another episode. Well, the other thing was because I was already on paracetamol, regular paracetamol, antibiotics, 2 antibiotics. The only thing left for them to add was giving me some form of anticoagulation. So the hospital gave me subcut heparin for 2 weeks. And so we came home, started taking subcutaneous heparin. After that, I think I had another 2-3 episodes of fever, but on that same night, again, my temperature gone up to 104. Again, I was holding my nerves, thinking that just in case if I end up going that night, I would be definitely back in the hospital. But fortunately, the temperature came down and I didn't get better with straight away, but it took another 2-3 days for my respiratory rate started coming down to sort of 22, 20. I was still feeling tired and lethargic, but I was okay otherwise, eating, drinking, no GI symptoms. So wherein you could say, I just want to tell, within the family, we took so many precautions, we end up all of us having it, wherein my wife symptoms started with diarrhea. And so we all had a different spectrum of disease. Both boys, who is 11 and 15-year-olds, their symptoms only lasted for 4 to 5 days. All that they needed was only paracetamol for temperature management. They also took vitamin D, vitamin C, but apart from that, they didn't require any higher level of medication. Wherein my wife, she had what I would say is upper respiratory tract infection and some GI symptoms. She didn't have tachypnea. She didn't struggle with her breathing. And but she had antibiotic, which is azithromycin, wherein in my case, because it was COVID pneumonia, I ended up having 2 antibiotics. I also required anticoagulation, wherein my wife didn't require the anticoagulation or DVT prophylaxis. So it's a different spectrum for all of us. And luckily, I managed to stay at home. It took another 2 weeks for me to get better, wherein my acute illness lasted for about 2.5 to 3 weeks. So in total, by the time I would say I'm more or less back to normal, it was about 5 weeks. And as I said, I'm 46-year-old, fairly fit, but the only comorbidity was hypertension. So people with hypertension or diabetes, irrespective of their age group, they're slightly higher risk. But obviously, if you're above 65, your risk goes up. I mean, with increasing age, your risk goes up. So that was my personal story, my personal war against COVID. But honestly, I had so much support from friends and colleagues in terms of food, in terms of delivering medication, in terms of having prescriptions. And then other thing is, by 3rd or 4th week of May, this sudden surge of COVID, which really hit hard UK in March and April, it started coming down a bit. So people who died. People who were on ventilators fighting long battle, they were fighting it. But in terms of number of admissions started coming down. That means, fortunately, we had some beds in ICU. So I had that psychological advantage that just in case if I get worse, there is a bed for me ready to go. So there are lots of different factors in there, how I kind of manage myself. But the talk is intended to give you all some tips to manage mild to moderate disease at home, just in case if we can't manage to get into hospitals, either because of the scarcity of beds and things. So that was my personal story, but I just want to run past a little PowerPoint presentation. Probably Vijay may have to give the permission to share the screen.
You can press share screen. Have you pressed your share screen there?
Yeah, it's
Below
taking
your screen.
Yeah, it's taking a while. Just
okay, good.
I don't know.
That was a really nice storytelling way of saying everything in detail, and that would have given a real good picture about 3 different types of presentation of COVID. Yours was relatively serious, and Swarna's was a bit lesser than yours, and the kids was even more lesser.
Vijay, you may have to refresh that button because it says host disabled attendee screen sharing.
Okay, now? Is it allowing you now?
No.
Okay, just one moment.
Hi, Vijay. Can I say something in between while you're setting it up? Just very quickly. Yeah. Hi, Srikanth. This is Shekhar Reddy.
Oh, hi,
I did dentistry from Osmania, and maybe I might have come across you in the hostel or campus, but I joined in '88. It looks like you are junior to me. Can you hear, Srikanth?
Yes, I can.
Yeah. Srikanth, I think Vijay has already given you the kind of audience that we have. The couple of things during your presentation, can you give clarification on, there's one thing about paracetamol doses. In India, what is prescribed is a very low dose paracetamol. It's not correctly weighed upon or measured against the patient's body weight. I think that's one thing that if you could clarify. And the other thing is, is it anticoagulation only, or antiplatelet medication also works? Or is it something that can be given prophylactically the moment you start feeling symptoms? Or is it only for severe cases? If you can clarify on that. And also you mentioned about oxygen saturation at rest, and also while you undertake some amount of exercise. And during your presentation, if you could clarify give some more information about these
few things.
It was a very good narrative, like you, I think, gave in a very nutshell of how you managed a scenario of actually COVID from mild to kind of severe. I think the key thing here is the basic minimum things of charting out temperature, blood pressure, respiratory rate, and the saturation. And you practicing the deep breathing exercises and your inhalations, etc. I think
most of the access for the presentation.
Yeah,
ready?
Can you check if you can share now?
Yeah.
That's it.
Okay,
I
I'll
think
leave it now.
He will cover a lot of that in the presentation, Shekhar. So yeah, please go on. Yeah.
Can you all see?
We can see 70%. That's perfect.
I think put it in slide share mode, slideshow.
Slideshow will give a full screen, yes.
Yeah.
Perfect.
Is that better?
That's good.
Yeah.
Because the slide share,
Slideshow.
Slideshow, not share.
It was just getting out of the screen. I tried that.
Now it is good, Srikanth. Please
It's
carry.
enough. Yeah.
Okay. So, as I said before, this talk and presentation is mainly to manage mild to moderate disease at home with the advice of another doctor. Either it's a telephone consultation or video consultation. But obviously, again, you need to have testing done to know whether it is positive or negative. So I'm sure you all understand the limitations of the talk. And the other thing is, I actually prepared this talk about 4 or 5 days ago because I was being asked by my relatives and friends who are of my age or sort of slightly older, who got diabetes and other problems. So this presentation, the PowerPoint presentation, is intended for sort of non-healthcare professionals in a very simplistic layman terms. So it's not sort of designed for a medical meeting. So just I want to clarify that. Can you see the slide properly, Vijay?
I think the right-hand side is the left-hand side. Yeah, that's better.
So the first couple of slides are sort of gearing up for it. As I said before, at home, we were starting this preparation from February onwards. Start taking vitamin D, start taking vitamin C, and good nutrition and all those things. So the first slide what it says is to boost your immune system, you need to do whatever you can to prepare your body to face the infection, assuming that we all will get it at some day or the other. So part of that preparation was, as I said, vitamin D, which was very well proven in the last, I would say, 2 to 5 years as a sort of magic bullet for a lot of other conditions. It's been linked with even like prevention of heart attacks and strokes, and it got a role even within the cancer treatments and preventions as well. But anyway, coming back to immune system, there was definitely a lot of published research about how vitamin D can boost your immune system. So I'm not a physician. I took this advice from who is a physician from India, actually, who is a chest physician. So here he said in India, you get this 60,000 international unit, wherein you can take once a week up to 8 weeks, followed by once in every month. Then vitamin C, because it's only preparation, you just only take 1 tablet a day. But in terms of vitamin C, you know, I would say natural supply in terms of oranges or any vitamin C enriched fruit can be very good. Okay, can you mute everybody else, please? Okay, so vitamins in terms of tablets as well as the fruits and all the vitamin C enriched stuff, oranges, lemon juice, etc. And then I put ginkgo with because I didn't know whether you would get a combination of vitamin C with zinc, wherein that's what I had it here at home. The point about zinc is apparently at the time of exposure, or if you think you're working in a very high risk environment where you may get exposed to COVID, apparently the zinc plays a role wherein it will stop the virus interaction with human cells or reduce its entry into the human body. but I put Zinkovid because I didn't know the name of vitamin C with zinc in India. So if you can't get that preparation, then you can just take Zinkovid. And in terms of nutrition, I'm sure you all know what to take, plenty of vegetables and high protein diet. The couple of other things is exercise. There's huge amount of medical research published in terms of people who do regular exercise, walking, running, or yoga, any form of exercise that proven to strengthen the immunity. And then in terms of sleep, again, you're all hardworking professionals, sometimes, late running clinics and people don't sleep till midnight and then early hours rushing again. Just to making sure that a good quality sleep, at least I would say 7 to 8 hours of good quality sleep for adults, and for kids about 9 to 10 hours. It's definitely proven to reduce the stress levels within the body, and it will improve the mental health, which indirectly boosts the immune system. And if you're a diabetic, obviously keeping the diabetes under control is at most very, very important thing. And in terms of symptoms, I'm sure I don't need to educate you all on the symptom side. You all know all those symptoms, but as I said, 2 out of 4 of us, they had diarrhea. 2 of us didn't have diarrhea. So diarrhea or some sort of stomach upset could be your first sign or first symptom of COVID. So don't think that's totally different thing. Let's say once you contracted the infection, obviously first thing is try and get a test done and then speak to your doctor. But here are the tips, as I ran past the story. The fever management, the fever, again, it depends, it can be very variable. As you all notice, up to 30-40% infected population are asymptomatic. They don't get the fever at all. But in terms of if you're having mild to moderate disease, you may get temperature, and the temperature can go up to 103 to 104. Well, anything above 100 degrees, but in my case, it was about 104. And the monitoring, what you need is, as I said before, you need a thermometer, you need a pulse oximetry, you need a blood pressure machine, and you should start counting respiratory rate in case if you start feeling tired and lethargic, or if you're feeling more unwell. You don't need that right from the day one, but it depends on your symptoms. So if you measure all these things, let's say 2 or 3 times a day to begin with, and as symptoms getting worse, you could go up to like anywhere between 4 to 6 times a day, and then keep a record of it. Then you yourself will know whether it's deteriorating or not. One thing I must admit is, when my symptoms were on like day 9, I didn't realize that I was breathing at a rate of 26 or 24, because it's a subjective feeling. You don't feel it. Wherein, because my wife is a GP, she used to stand far out, but she used to count how fast I'm breathing. So objective measurement and recording is a very, very different way of monitoring, and it's more useful rather than thinking that my breathing is okay. It may not be okay. I'm sure you must have heard this term called silent hypoxia. We have known a lot of patients, they present to doctor or hospital with some of the symptoms. They don't realize that they're hypoxic. First time saturations, they would record something like 85 or 90. They don't look breathless at all. So those symptoms, those are the things called silent hypoxia, which can be very, very dangerous. And the other thing in terms of, measuring saturations, as long as all your measurements are okay, and at least, once a day, you could do sort of quick, either taking up and down the stairs, or you could do 50 to 100 meter, sort of like a fast walking, not leisurely walking, and then check the oxygen saturations. So that's what I mean by checking the pulse oxy or oxygen saturations on exercise. So that is again well observed that in certain patients, saturation drop on the exercise, but they're okay when they're resting. In terms of fever management, yeah, here in UK, for all the adults, we take 1 gram up to 4 times a day. Wherein I think in India, it is not a normal practice to take 1 gram. I think people
50
generally
milligrams.
take, yeah, Dolo 650 milligrams. There isn't a, well, the per kilo equation only comes in children rather than in adults. Wherein in children, it is like 15 milligrams per kilo dose. And in terms of fever management, especially if your temperature is very high grade temperature, let's say above 100 or 103-ish, you could use tepid sponging, use a fan, open the windows, good ventilation. But we all tend to have this tendency, once you start shivering, we add more layers. Which that means your heat is not dissipating. That means your temperature even get further worse. So even if you start shivering, start taking layers off and then, use tepid sponging. You can use ibuprofen. I said it's with caution. That's because there was a lot of talk that ibuprofen could make things worse. But again, that guidance has changed by WHO. So you are allowed to use ibuprofen for fever management. But again, let's say if you are dehydrated or if somebody old age with known kidney problems, then you've got to be careful, because ibuprofen is one thing can make acute kidney failure worse. So you've got to be careful. Only if you have to use it for limited doses, not like a regular 3 times a day. Maybe occasionally if fever is not getting better with the paracetamol. If you haven't already started the vitamin D, you could take up to 4,000 units per day while you're got the infection. And in terms of vitamin C, there isn't actually, you can go up to like 2 grams per day safely without having much problem. Higher the better. And also some sort of form of zinc or ginkgovit. I would say, we can continue these vitamins for at least 4 weeks during the first 2-3 weeks of acute illness, as well as the recovery period of another 2 weeks. And symptoms usually start resolving by end of first week in majority of the patients. But generally speaking, if you have moderate disease or moderate to severe, it could take up to 2 to 3 weeks. Again, I don't want people to sort of start their own medication, left and right, but these are the few tips here. The antibiotics obviously will not cure the COVID itself. Antibiotics are mainly to prevent the secondary bacterial infections. Azithromycin and Comoxiclav, those are there. And in terms of moderate to severe disease or people with high risk factors, I would say people who got hypertension, diabetes, or chronic kidney disease, or any chronic respiratory illnesses like asthma, COPD, or people above 60-year-olds, they would need some form of anticoagulation. When each country is doing it differently, each system is different. In my case, I had 2 weeks of subcutaneous heparin because I went to hospital. But rivaroxaban is something, it's called Novak, novel, and they sort of slightly anticoagulant. I put rivaroxaban basically because here in UK, it's been used as a for DVT prophylaxis, 10 milligrams once daily after joint replacement surgery, like knee replacement and hip replacement. People go home after the knee replacement within after like 3-4 days, but they remain on this tablet for DVT prophylaxis, which seemed to be relatively safe and effective. And after, in my case, after stopping the heparin after 2 weeks, I took the rivaroxaban for another 2 weeks.
It is
So,
available here as well.
oh, that's good.
Yeah,
Yeah.
it's available. I bought it from my brother, but we didn't actually use it because he had heparin in the hospital. It's certainly
Right.
available here.
So for moderate to severe cases, people say 4 to 6 weeks. But it all depends on your risk profile. You know, it's not the same medicine for everybody, especially anticoagulation. You need to go through side effects and contraindications if somebody already had certain bleeding disorders or something, you know. So people have got to be careful. But the reason anticoagulation is important, it will come in the next slide anyway. But if you're already on aspirin, please continue to take the aspirin on top of the rivaroxaban. Oops. So when it comes to other medicines, obviously you must have gathered a lot of use of antiviral drugs, especially the remdesivir as well as the favipiravir. I think these two drugs came into the practice. Personally, I would say, well, 2-3 things categorically I can say. One is they have no place in terms of management of mild to moderate disease. They have some place in hospitalized patients with the severe disease. But as far as I can see, there is not adequate research on these medicines. I think in the middle of the pandemic, certain drugs sort of creeped into the market without much scrutiny. The remdesivir has published only 2 studies or 3 studies so far, but there isn't any proven mortality benefit. These both drugs came into market with saying that, oh, it will reduce it will fasten the recovery. I think in remdesivir case, it is like, oh, your recovery could be faster by 4 days. But in Western country, I think in US, the cost of remdesivir is about $3,500 per course. And I don't know the cost of favipiravir, but again, they both are expensive drugs. They have their own side effects. They can change the liver function test. So personally, the most important bit is you wouldn't need those medication if it is mild to moderate disease and if you're staying at home. And the dexamethasone, again, this is the only proven drug in terms of improving the mortality, improving the survival, or reducing the mortality, which was tested and trialed in recovery trial, for which I was the principal investigator in Royal Blackburn Hospital. But again, the dexamethasone has only shown to be beneficial in the patients who required oxygen, not in the milder disease, not in the moderate disease where people generally don't need oxygen. So that distinction people have to realize. But obviously, you know, when you're anxious, when you're scared, I know a lot of patients are taking dexamethasone at home as well. But again, I'll come on to that point in a few minutes. Hydration, as I pointed before, you know, adequate hydration up to 3 liters in different forms is very, very important to prevent the acute kidney injury. Nutrition, again, obviously that's linked with boosting your immune system. And the general trend is, you know, as soon as you fall sick, you know, yeah, just avoid normal food and stick to like milk and bread and all that soft diet. No, don't do that. Just eat what you normally eat. Avoid spicy foods and avoid whatever the food that could worsen the diarrhea. But in fact, take good, you know, fruits and nuts and eggs. So whatever boosts your immune system, that's very, very important. Avoiding blood clots, that's a bit I was concentrating. the biggest distinction between COVID and other viral infections or previous, let's say, pneumonias and other diseases is this particular infection is now known to cause microvascular thrombosis. That means, lots of microclots, especially in lungs, kidneys, and other organs, even like peripheral limbs as well. So it's associated with vasculitis and clotting problems. So it is very, very important to take all the precautions to prevent the blood clots. And the risk is higher in old age people and people with hypertension, diabetes. So along with sort of, mobilization is very important to prevent the blood clots. Keep moving every few hours and don't do heavy exercise that makes you short of breath, but keep moving is important. And in terms of medicines, as I said before, aspirin is an antiplatelet drug. If you're already on aspirin for something else, you could carry on. But personally, I think it is more sort of drugs like either heparin or rivaroxaban, which is anticoagulant, that seem to be more important than aspirin itself. Within the hospitalized population, we haven't seen a great deal of thrombocytopenia or platelet dysfunction for that matter. So if you're not on already aspirin, you don't need to take aspirin. But I know a lot of doctors have taken aspirin in US as extra precaution. There isn't a sort of, I can't give 100% on saying that aspirin is completely useless. I can't say that. But there is no research, there are no published studies with aspirin in COVID yet. The mental health side, well-being is very, very important aspect, especially if, as a family, if you're not sort of geared up, suddenly you feel frightened and shaken up that, oh gosh, you got COVID. So obviously, now that you're in the middle of pandemic, especially in India, infection is spreading really fast. So you just have to assume that at some day you will get it. So you rather than sort of struggling with fever and anxiety, the better you prepared, the better you face. Concentrate on the positive facts, especially the most important bit is 90 to 95% of younger population, they don't need hospitalization. And again, anywhere up to 80 to 85% of older population, they don't need hospitalization. Predominantly, most of them either symptomatic or they have mild to moderate disease. So concentrate on the positive side. And let's say you get it as a family, one of the family members get it. Avoid watching news, especially in the TV and social media. It tend to be quite dramatic. They focus more on the people who died rather than people survived. And so you don't get to the good news. You only get to the bad news all the time. So you got to be careful where you pick up your news. But personally, if you're acutely unwell, I would strongly recommend just avoid watching the news, either on TV or social media. Just be in touch with one or two really good friends who could be really helpful to you. Other than that, just avoid, most of the time talking to hundreds of people, every day WhatsApping hundreds of people. It just doesn't help really. Just take rest, listen to whatever the music, either Telugu, Hindi, whatever you like. Watch your favorite childhood movies, whatever it can take you back to old memories. Do some activities as a family together, like playing chess or online games and things like that. But the other thing is yoga was found to be very, very helpful. Yoga or meditation, both. And within the yoga, you have certain things like pranayama, which will help with the deep breathing exercises. This slide is mainly about steps to avoid hospital admission, I would say. As a family, we found steam inhalation was really helpful. We used to use, a little bit of Vicks in the hot boiling water, and then you cover yourself with a towel and just to take steam inhalation. But unless you put it like, okay, I'll do it whether I'm okay or not, sometimes people tend to ignore and they may end up leaving these things too late. I don't know. But we did it right from the beginning and we found it very useful, clearing your sort of upper airway and deep breathing exercises. You can find them on the YouTube. There was some on the Twitter as well. The main thing is you take what it is basically you're trying to expand your lung bases and improve the gas exchange across the alveolar membrane. So when I say deep breathing exercise, what it means is each time you take a slow inspiration and then hold your breath for about 5 to 10 seconds and leave it. So if you repeat that same thing for about 10 times, that sort of classed as deep breathing exercise. And then you could do it at least 2 or 3 times in a day. Especially when you're acutely unwell, even with mild or moderate disease, these things, again, improve your lung function, and then they will help you to keep away from the hospital. And if people are already doing yoga, that'll be better. That will have certain form of deep breathing within the yoga. And then the other thing, most important thing is using the prone position. Even when people they're not hypoxic, but when they say if they feel tired or lethargic, they used to find prone position is really helpful. After using the prone position, people feel less tired. It can only last for a few hours. That means you may have to repeat prone position again, but it's very important to use it like at least 2 or 3 times in a day. And in the nighttime, use it as much as possible, as long as possible. As Vijay showed that picture, it's a swimming position, one arm up, one arm down, or it's up to you how you make it comfortable for yourself. And this position expands the back of the lung. Normally, when we lie down in supine position, you're lying on most of the posterior part of the lung, which is probably 30-40% of your lung function. So by lying prone position, you're giving the posterior part of the lung to a chance to expand. That will obviously improve the oxygenation. Prone position is one of the very well proven and a simple technique that will improve your breathing, and it will help you to avoid the hospital admission. You definitely don't need any intravenous medication unless the disease is really severe or unless you need hospitalization. So in mild to moderate disease, when you can sort of stay at home, you just don't need any injections at all or any IV medications. And you don't need CT scan for mild to moderate disease. Well, here in UK, even in the severe disease, we didn't do CT scans on every hospitalized patient. We only did CT scans to rule out pulmonary embolism, or unless we suspect pneumothorax or pleural effusion or something else. But it's not for everybody. But I know the practice in India is different. And the symptoms and vital signs are enough actually to decide how bad your disease is rather than the CT scan. But again, this is my personal opinion. I'm not suggesting that is the guideline. But despite all these things, honestly, if you feel really short of breath, if your symptoms are getting worse, you need to go to hospital. People may need oxygen for a short period of time. And dexamethasone is only for hospitalized patients. And duration of illness, usually mild disease tend to last about 7 to 10 days. A moderate disease, well, in our case, my wife sort of had it for 2 weeks, and in my case, it was up to 3 weeks, roughly 2.5 to 3 weeks. But sometimes you notice you got the symptoms for the first week, and then you get a break for a day or two, and then it will come back again. So you got to be careful just to don't jump to the conclusion too soon. And second week is really important to keep an eye on things in terms of whether you're going to get shortness of breath or not. Generally speaking, the majority of the people, they don't get short of breath in the first week. It is usually the second week. And severe disease with shortness of breath will last longer. It could be, it depends on how bad it is, whether you needed mechanical ventilation or not. Again, recovery depends on how bad was the disease in the first place. It usually anywhere between 2 to 4 weeks for a moderate to severe disease. And in severe disease, hospitalized patients, it could be up to 4 to 8 weeks. Symptoms such as fatigue could last longer, up to 2 to 3 months. You might have noticed in the media, there's a new word called like long haulers of COVID. That means they have symptoms even after 3 months, but it's exceptional, it's rare, it's not common. But good nutrition, exercise, meditation will obviously expected to fasten the recovery. So that's my presentation. I would stop there now. Do you?
Thank you very much, Srikanth. Yeah, please go on.
So I'll just come back in a second. If you can sort of start checking questions, I'm happy to sort of answer the questions.
Okay, there is a couple of questions already. You want to take them now?
Yeah.
To have a few minutes, or you want to take them?
That's fine.
Okay, good. There are a few questions here.
Yeah.
From Sridhar Kodumuru, Dr. Sridhar Kodumuru. He would like to know the dosage of rivaroxaban and number of times based on illness.
Well, in my sort of experience, or my recommendation is, if let's say young people who have no comorbidities, mild disease, probably they don't need it.
Yeah.
It is people who have comorbidities, or people who are older population, people who are already on immune suppressed drugs, and wherein we think they've got high risk. In those cases, rivaroxaban is recommended. The dose is 10 milligrams once daily. And if it is moderate disease, I would say they can have it 4 weeks. But let's say if they end up going to hospitalization to the hospital with severe disease, they recommend up to 6 to 8 weeks.
Right. That's
but
brilliant.
You don't take heparin as well as rivaroxaban at the same time. You only take one or the other.
I think that answers the question. The next question is from Dr. Srinivas Gadipalli. Is there any specific isolation? Is it required in a family, or can live together with family members?
Well, there is a document released from actually WHO guidelines, how you isolate yourself within the house. There's about like 2-3 page document, which, well, I have the copy of it. I can send it to you, if anybody wants. There's very clearly, with clear instructions, how to isolate, how to follow infection control methods. The problem here it is it depends on how big is your house, whether you have a separate bedroom with attached bathroom.
Yes.
The first person who gets it, obviously he needs to go into one room, he or she. And then they need that separate bathroom because they just have to live there. And the food should be delivered just outside the door. And then those people should not come out in contact with others. And that means that room should have adequate ventilation, big open windows. They should be able to sort of get some fresh air. Just in case if they have to come out, obviously, rest of the people should have masks. The person who got the infection should have masks. So it's a lot more detailed, but it all depends on the personal circumstances. And all the people can't be in one room, basically. That's completely. And let's say if the infected person come into that room, then again, door open and leave some fresh air come and go. So
this is all, I guess, because you want to keep the virus load as minimal as possible.
As minimal as possible, absolutely. And that is the reason why in sort of in most of the countries, even in India, the governments have taken these steps where they build these isolation centers. We should not call them as hospitals because they don't have oxygen supply, they don't have full staff nursing and doctors. But what they have is, you have just beds, you have food, you have certain basic medicines will be provided. Those are called isolation centers. Those are purely designed for the people who can't isolate themselves at home, but they have to go to this isolation center and then stay away from the family.
That's great. I think that answers the question. Next question is from Dr. Bhargavi. I'll just read out the question. My question is, in arrhythmic patients, how to differentiate the breathlessness, whether it is due to arrhythmia or is it due to COVID in asymptomatic patients? Dr. Bhargavi is a maxillofacial surgeon. Did you get that question?
Yeah. In patients with, is that with asthma or arrhythmia?
Arrhythmia, it is.
It's arrhythmia, sir.
Arrhythmia.
Okay. Well, there is no sort of, the testing is the crucial bit. The testing is absolutely crucial to answer your question. So it's very, very difficult to distinguish between any other cause to COVID causing shortness of breath. Within our own ICU, we had several situations wherein, as clinicians, we were absolutely convinced that this is definitely COVID. But then we did several testing. In one, few patients, we did like testing 5 to 6 times, including the bronchoscopy, lavas with the proper sputum sample, but they remained COVID negative. So that means what it is you'll have a lot of other diseases existing in the community, existing in the patient population that would cause shortness of breath. So not every shortness of breath can't be ascribed to COVID. So the repeated testing is the key there.
That's great. Next question. There are a lot of questions.
Dr. Vijay, this is Dr. Ratwalikar here.
Yes, Dr. Ratwalikar.
Can I ask a question?
Yeah, please go
on. Have you tried betadine gargle or betadine nasal sprays, or can you throw some light on role of betadine in this particular as a gargle or as a nasal spray, doctor?
I suggest.
I have seen several sort of articles or WhatsApp videos, but I haven't read anything scientifically sort of peer-reviewed article or publication about these things. Maybe it didn't attract my personal attention, but I didn't do it. The bit I kind of struggle with this kind of concepts is, let's say, assume like common cold. Yeah, it's a coronavirus. Once the virus come into contact with your body, with your mucous membranes, and it all depends on the virus interaction with the host, with your immune system. And trying to sort of physically flush out the virus, I don't know, I just struggle to understand that concept. I haven't seen any published scientific studies. I know some doctors strongly recommended this anterior nasal cleaning. Yeah. I haven't done it myself. I don't know, and I can't recommend without me being convinced myself.
The next question, it's Srinivas Gadipalli again. What he is asking is, will deep breathing push the virus from the throat to the lungs?
It's I don't know. What it is it's again, we all try to sort of cling on to this sort of concept that virus simply get into the nose and then go down traveling. I don't think that's the way entirely it works altogether. I don't know. What it is it's well, if I can draw some parallels from, let's say, different diseases like sepsis, pneumonia, it all depends on the bacteria or virus interaction between the pathogen and the host. That interaction is the most crucial thing, which will decide whether a patient is asymptomatic, whether a patient got mild disease, or whether a patient admitted into intensive care. Well, just think about what we know at the moment is there's a significant amount of infected population. Anywhere between 20 to 40% of infected population remain asymptomatic. They have the virus. If you do mass testing, you will have 30% of patients, they don't even know that they got the virus. They're not doing this anti-nasal cleansing and all this. They're not taking any deep breathing. They have the virus in their body. But because of their interaction, their immune system interaction with the virus, they remain asymptomatic. So I personally don't think that deep breathing will cause more harm. What it does is it improves the lung function, it improves the oxygenation, it relieves your symptoms. Because at the end of the day, it's the virus attacks wherever is the ACE receptors, it's angiotensin converting enzyme, ACE receptor. So wherever the ACE receptor abundant in your body, in the lungs, in the small intestine, in various other parts of the body, that's where the virus keeps on entering. It doesn't matter. It's just so the symptoms are kind of related to the organs where you got it.
Where it's entering from.
That's
There's a lot
right.
of questions. Thank you, Srikanth. There's a lot of questions. A lot of people are thanking you. Obviously, they have been listening keenly and they felt that it's quite useful. I will go to the next question by Dr. Subhash Gattu. Can we use rivaroxaban as prophylaxis even when we have not contracted with COVID?
It will be, personally, I would definitely say no, because it's an anticoagulant, it's a small dose, I understand that. But when people are on anticoagulants, even a trivial trauma, unintended trauma, any minor accident can cause to the bleeding. So you've got to be careful. This is only recommended in acute illnesses or for certain indications. I have to make a disclaimer here. I don't think rivaroxaban actually licensed for purely, in this circumstance in the COVID. The lot of off-license practicing is going on. So
it is available in India over the counter almost. Yeah,
absolutely. But you got to be careful. These drugs can cause bleeding, so it's definitely not recommended as a prophylaxis.
Question from that one: can it cause internal bleeding at all if used? Say, okay, we don't use it for before we get it, but if we get it, can we use it without any fear of having some internal bleeding or anything like? Is it fairly safe?
It is fairly safe. After going through the sort of screening questionnaire, let's say you had a condition like DU ulcer, duodenal ulcer, or if you already suffer with gastritis, then you've got to be careful. If you have any other condition which could put you at risk of bleeding, like some sort of hemoglobinopathies or some sort of hematological conditions.
Absolutely.
But generally speaking, if you're not on any medication, if you're otherwise healthy, it is safe enough to take.
Next question. There are a lot of questions, so I'll just go a bit rapid fire style. So Ram Sunil, when should we get tested and when we shouldn't?
That's a very good question. Each country has taken different approach for various reasons. One, certain countries don't have the capacity to do the mass testing. So what they're doing is they watch a community area, one particular area where there is sudden surge of cases. Then they'll say, oh, any patient, anybody can go for testing in this area.
Yes.
So that is what is happening in England. In England, this first surge actually now calmed down. The nationwide figures are coming down. but in a place called Leicester, suddenly there's a huge surge. So within the Leicester, anybody, even whether you have symptoms or not, you can go for testing. When coming back to address your specific question, it depends on your risk of exposure. Let's say if you're working in hospital environment, if you're working in COVID areas, probably you should be testing every week, because once you get tested, you kind of okay for a week, but then after a week you need another testing.
Better to test.
And that is how they're doing in most of the UK hospitals now, wherein they're bringing non-COVID patients for operations and surgery. They say it is a green pathway. That means the staff who are working in that particular area of the hospital, they'll get tested every week.
The next question, can I go?
Yeah.
Yeah. The next question, Sridhar Kodamuru. What is the use of tocilizumab in COVID? Is it really worth? It has shown a lot of relief in severe COVID patients, and it is very expensive.
It's a drug, belongs to biologic drugs, and is mainly used by the rheumatologists. It is classed as some sort of anti-inflammatory drug. And the reason that came into the management of COVID-19 is because in the COVID-19, in severe and hospitalized and critically ill population, it is, well, there are three things what makes the disease worse. One is, first of all, the viral infection itself. Second thing is the secondary bacterial infection. Third thing is the microvascular thrombosis. And the microvascular thrombosis is the one which is triggered by something called cytokine storm, wherein the tocilizumab is aimed to suppress that immune response. And it does work, I believe, but again, there isn't a big published data out there yet. There are at least about 6 to 8 randomized clinical trials are running at the moment, but the results are not out there yet. Again, it is a very specialized drug. It should be prescribed only for hospitalized and critically ill patients. It is not something for mild to moderate disease.
One question, I don't know if it does make complete sense or not, but does not dexamethasone do the same thing, reduce the immune response, interleukin-6 and all that kind of stuff, instead of, because dexamethasone is extremely cheap in India compared to this drug. What's your opinion about that, Srikanth?
I personally would like to see, let's say if I live in an ideal world, we could do a randomized control trial comparing with dexamethasone versus tocilizumab.
Yeah.
And then that would make a great deal of sense. But I don't think there is a trial doing that. But you're absolutely right. To a certain extent, dexamethasone would serve the same purpose. And the dexamethasone in the recovery trial obviously, has shown a huge deal of mortality benefit. And wherein in any study, it is yet to be seen actually whether tocilizumab would achieve the same thing. What drives all this use of all these expensive drugs is panic, fear, loss of rational and loss of logic. When you're desperate, and that is what
industry-driven research as well, I guess.
Yeah.
So next question, Ramya Krishna, Dr. Ramya Krishna, how will be the fever? Will it be continuous or it will come and go off? How much temperature should be considered as COVID? What symptoms can we see other than fever? I think you've gone through this in your lecture, but if you want to briefly
usually the fever comes and goes, spikes like 2 or 3 times a day, usually in the evening or night time. And then each time it may last up to 2 hours. But again, every individual is different. Everybody's response is different. There isn't any set temperature where you can say this is definitely COVID. COVID is only proven by testing. That's it.
Perfect. Next question.
Dr. Karu, sorry to barge in again. Dr. Atulikar here.
Sure.
Extremely sorry to barge in. But there is a lot of this thing going on among medical professionals to take MMR vaccine and flu-vac vaccines. Flu-vac, of course, will prevent the influenza. But have you in your country heard about it, or the role of MMR vaccine? Because for our age, 50 and above, we never had this MMR vaccine in our childhood. And it seems the measles vaccine has got measles virus is almost 30% similar to corona COVID virus. And that's why there are some studies, not official again, done, and they said that MMR vaccine is doing good. Can you throw some light on it in case you know?
Well, direct answer is no. There is no proven role for MMR vaccine in the management or fight against the COVID so far. But I read few articles in New York Times when, back in February, back in March, because the infection is spreading really fast, millions of people are dying. The vaccine specialists, immunologists, were taking 2-3 different approaches. The first approach is obviously you try and invent a vaccine that is directed against the COVID, wherein the second approach is you already have a lot of available vaccines, including MMR, one of them. Why don't we try these already existing vaccines in a randomized control trials and see what works, whether it works or not? It's purely in the research idea, but I don't think it's proven concept. And that's what I know.
Thank you, Rob, sir.
We can't hear Vijay.
Can you hear me now?
Yes.
Good. Next question is, what is this thing about kashayam? Everyone here speaks of it. Does drinking a concoction of herbs and spices really help? It appears anecdotal. Same thing about turmeric. You can answer, or I can answer this.
The thing is, honestly, it all depends on what you believe in it or what you don't believe in it. Personally, as far as my knowledge goes, these things have sort of deep-rooted ancient practice within Indian Ayurvedic medicine. There seem to be certain level of benefits, but obviously, given me as a sort of practicing as a critical care physician and practicing with randomized control trials, I haven't seen any of those kind of trials using these herbal medicines. So I can't answer your question in that concept, but in terms of anecdotal evidence, they seem to be, historical anecdotal evidence, and it all depends on what you believe in and don't believe in it. When you're using so many different interventions, which one worked, which one didn't work, it's kind of hard to say. But let's say indirectly to answer your question, there are there are lots of countries outside India, millions of people outside India who never used any kashayam. They never used any of these herbal medicines, but they're still people getting better with COVID. So do you definitely need to use kashayam to fight against COVID? Definitely not, but it may be useful in terms of some sort of symptom relief.
Yes, I have gone to the internet and Googled and saw some papers about these kashayams, especially ginger, pepper, turmeric. And they seem to have some papers on the internet saying that it boosts the immunity. So we'll go to the next question now.
Yeah.
Dosage of vitamin D for children.
Personally, I can't answer that question. I'm not a pediatrist,
I think that advice should be taken from a pediatrician. We'll go to the next question. Dr. Ram Sunil, is that once we have been positive, we won't be affected once again? There's a question about reinfection. How much immunity does it?
Well, the two folds. One is I'm yet to see any officially published case series of reinfection rate. There is no published paper yet. Second thing is there are constant efforts, especially in South Korea and China. They went on retesting people several times to find out whether there is a reinfection appearing. apparently even after several weeks, certain people tend to shed the virus, either in the urine sample or in the feces. But what the scientists are still working on it is whether finding some sort of viral genetic material is equivalent to having active infection. That is the question what they're trying to answer, but it appears not at this stage. We haven't seen any patients coming back with the reinfection, the same person, after a gap of, let's say, 2 or 3 months. And the other thing is the antibodies seem to last at least for a few months, if not years. So there's an ongoing research, but to answer your question, it's highly unlikely, but it doesn't mean that you could be sort of, going easy. You should still take, well, at the moment, I've recovered, I'm back to work, but I still have to wear full PPE kit on. I'll take all the precautions so that I don't get it again.
So the message is follow precautions as though you have not got COVID, even
That's
though
right.
you got it. So
That's
that's the message. So next question, does severity depend on viral load? How safe is dexamethasone in diabetics?
The viral load concept, again, it's purely to answer the question scientific point of view. There seem to be studies going on, and there's a lot of papers published in the immunology world. The indirect way to answer that question is probably yes. The more you are exposed in a repeated high-risk environment, i.e. if you're working in COVID ward, or the people like, again, anybody who is coming in contact with COVID patients repeatedly, probably they seem to have a high risk of having the disease, at the same time having a severe form of disease as well. So obviously you see, high proportionate rate of COVID within the healthcare workers. So that could be the link, but I'm not 100% sure about it. What was the second bit of the question?
The question was, does severity depend on viral load? The second question was, how safe is dexamethasone in diabetics?
Oh, it is safe. There's nothing wrong in using dexamethasone in diabetics, but obviously blood sugars will go up temporarily. It is not a long-lasting effect. And as long as you kind of taper your medicines to it and keep an eye on the blood sugars, you should be all right.
That's good. Next question from Dr. Hari Krishna. Clarification needed from Srikanth. What is the assumption in UK regarding the virus being airborne or is contact related? And what is the probable reason so many doctors are being infected? I think that's a very good question. Srikanth, did you get that?
Well, whether it is airborne or not, it's only appearing in the media for the last 4 weeks, 4 to 6 weeks maximum. And it's only recently WHO again started publishing some guidance sort of addressing that issue. Until then, it was not recognized as airborne. I think it depends on, again, which environment you're working and what is your own personal risk. I'm not got completely sort of deep knowledge about it, but it appears to be more sort of, as long as you take the existing precautions like social distance and hand washing and gloves and wearing full PPE when you're coming into contact with the high-risk patient, does seem to be solve the problem. Wherein in terms of airborne means, it has to be more infectious. A lot of people should be getting it. I don't know. I'm not.
Yeah, I do agree with you.
Masks seem to be the key in countries where it is being contained and well controlled. Those are the countries, apart from lockdown, they also implemented wearing the mask right from the beginning, like right from March. In those countries like Japan, Vietnam, South Korea, they seem to contain the disease better with the public cooperation who wear the mask all the time.
That's great. It
Yeah,
looks
thanks.
to me,
Thanks.
it looks like in closed spaces, it is probably airborne to a certain distance. What are the droplets are coming out?
Absolutely, that's right. Yeah, absolutely.
So in terms of we being dentists, we got to be very careful within our closed spaces of our dental clinics. So
Yeah, thanks.
question,
Thanks, Vijay.
thank you, Hari. Next
Yeah,
question, Dr. Shekhar Reddy is asking the trade name for rivaroxaban. I think it's Xarelto, isn't it?
That's correct.
Srikanth?
Yeah, that's correct.
Xarelto is the trade name, and in India, it's the same name on the box. So next question after that, dosage of vitamin D for children that you have answered already. We'll go to the next one from there. What is the duration they are asking? How long it should be taken? Once
Which
the
one?
dosage is assessed. Duration of vitamin D. How long we should take?
Well, the thing is, well, we started taking it before you get the infection, but you don't know when you're going to get the infection.
Yeah.
In that case, you just take once monthly, and unless you have any side effects, so you don't need checking. But obviously, vitamin D levels test is available. So let's say after taking 4 to 6 months or 10, 12 weeks, if you're worried about, am I taking too excessive? Obviously, you can
Hypervitaminosis.
test that. Yeah. Other than that, it is usually safe to take the medicine. It's okay.
Next question is Dr. Geetanjali Somisetty. Is HCQ prophylaxis still recommended? There is a lot of difference of opinion here in Telangana about it. Hydrochloroquine, is it? We also had a discussion, Srikanth.
It's been huge controversy. In some countries, it's been more popular than in others. In UK, it was never used against for prophylaxis reasons. As far as I know, the ICMR published one paper, and then there was another study published in New England Journal of Medicine from America and Canada, but they didn't seem to find any benefit to use as prophylaxis, whereas ICMR papers seem to suggest that there is some benefit. But when I read in depth that ICMR paper, the numbers are really small, and the methodology of research is sort of got its own flaws. Of course, they might have did their own best. It's a resource-crunched environment and it's a pandemic. I can't complain. At least they made an effort. But in terms of actual prophylaxis point of view, it's still not sort of convincingly proven that it works. But yeah, I know some people have taken, but the drug comes its own lot of side effects. Let's say, how long you're going to take it? Is it like months, and then there is
especially when it is prophylaxis. Yeah,
that's right. How many months or years you're going to take it? And then other question is, there is no agreement on what is the right dose or how often you should take it. It's been all over the place. There is no right answer found yet. So you may think you're taking the right dose, but nobody knows what is the right dose.
Right. Next question. This is a good question. Everyone has doubt about this. Can you please clarify, does the virus get transmitted through vegetables, utensils, etc.? And do we have to sanitize each and everything we get it from outside?
I'm not an expert in answering this sort of questions, but in terms of vegetables, obviously, if it is salads, clean properly and then eat it. And if it is hot food, obviously you wash and cook, and then that should solve the problem. In terms of surfaces, obviously I heard like it could stay up to like 2-3 days. But to answer the question, basically it's all essential. The way you normally clean, and that's all I can say. But there isn't any particular focus on the food causing or increasing the transmissibility of the disease.
That's good. Next
Dr.
question.
Vijay, can I suggest
yes.
that UVC box? I think UVC is proving it as far as COVID is concerned, and vegetables, keychains, all the paraphernalia like cell phones, these things can be kept in a UVC box, which is easily available now, and
Oh,
that
fantastic.
helps.
That's a good suggestion, I would say. Probably we have to turn the vegetables one way around after some
30
time so
seconds.
that, yeah. Thank you for that. We'll go for the next question. Dr. Koya Kishore, there's a question about reinfection. You have already addressed that. I think we'll go to the next question. Dr. Geetanjali Somisetty as well. Again, I am doing duty on call. Okay, that's not a question. It was a message for me actually. She's my niece. Then next question is, sorry to ask this, but even after taking precautions by you during treating patients, what could have been the reason for your infection?
That's
the
very
question.
good. Somebody asked me, I was waiting for that.
Yeah, even
Actually,
I wanted to ask you, yeah.
I wanted to tell in my story, but I missed that bit actually.
Thank you, sir.
This will actually tell you how important it is, the precautions what we take. We think the infection came to house from the workplace of my wife. She's a general practitioner. Here it is general practice. Her workplace is reasonably big with like 6 doctors and several nurses, pharmacists, and but by the time this is back in end of April or May, by the time they were stopping all the patients coming into clinics. It was mainly telephone consultation, but there were still like 20-30% patients who definitely had to come into the clinics they were coming in. But we think she didn't get the infection from the patient. It was a result of her talking to one of the colleagues in a closed environment. Then apparently the nurse came to talk to my wife, leaning over her, looking at the same screen of the computer for 2 to 3 minutes, looking at some numbers or reports. And then my wife went back into that nurse room. Again, the same thing. They both did not wear masks because the wearing mask was not essential or mandatory at that time. And then the assumption is we all think we only get it from patients, but we can get it from anybody. And especially if somebody is asymptomatic, you don't know that they have the COVID. So assumption in that situation was they both are healthy and they both were not carrying COVID. They both were, they both didn't take precautions at that time. And within a span of 4 to 5 days, well, soon after 2 days, that incident, that nurse became ill. And then within another 3-4 days, there are another 3 or 4 members of staff who were in contact with this lady. They all became COVID positive. So that's how we think we got it. Wherein I worked in a highly intense COVID environment with really sick patients, but because of the full gear, PPE and all that, because I'm more conscious that I'm definitely going to get it from there. And so that's what makes it a difference, The more conscious you are, the better you will protect yourself. So don't assume that, just because you're visiting a friend or other family, they don't have it. Don't think if you're going to visit your brother's house or sister, they may got it. You don't know.
Take universal precautions.
Absolutely, all over.
Even in the society, not just in the clinic.
That's right.
That's one thing. The next question is, we have all dentists, we have started using pulse oximeters and infrared thermometers. So this question is from Dr. Swarupa. She's asking, is a saturation of less than 94%, is it a strict no to attend a patient for dental treatment?
Well, you need to know why somebody's saturations are 94, because having 94 saturation is not normal. Unless they have severe COPD, unless that is normal sats for them. A general concept is, older people may tend to have a little bit of less saturation, but again, you need to know what is their normal saturations. So unless you know the answer why they have 94, you can't say yes or no. Plus, depends on what treatment you're offering, how long it will take. You don't
Yeah.
want any disaster within your own clinic.
So it's definitely low and it's probably best to avoid.
Absolutely.
Good. The next question from Dr. Ramya Krishna. How will be the fever? Will it be continuous or will it come and go? I think you have answered this question. Yeah. Role of LL6, interleukin 6 in this COVID. That's a technical question if you want to answer. Interleukin 6.
I have limited knowledge, but all that I know about interleukin 6 is it's part of that cytokine storm, and then drugs like dexamethasone and tocilizumab tend to sort of affect the IL-6 levels. Yeah.
What symptoms can we see other than fever? You have covered there are 55 questions more, so I will skip some questions which you have already answered.
About HCQS prophylaxis, if we can highlight.
I thought we just answered that, didn't we?
Yeah.
For dental surgeons, is it advisable?
Oh, I thought we answered the HCQ prophylaxis.
Yes, we have answered.
My personal view on that is it doesn't work. There is limited research. One randomized control trial published from Canada and America, they said no benefit, whereas ICMR said there is some benefit. But again, there's a huge debate about how much dose, how long you will take. But personally, I would not recommend it. I don't see the point of it.
That's great, Srikanth. Next question is about oxygen concentrators are being sold in Hyderabad. They're selling and renting them. And a few people are buying oxygen cylinders as well. So a lot of us dentists have oxygen cylinders in our clinics, which we can use in emergency if we have to. So my question is, and the question of one of the persons here is, are oxygen concentrators useful, number one? And number two, if we have to give oxygen in a case dire necessity, we are treating the patient at home or ourselves at home, oxygen, how we should administer it. I know when we turn the knob, it goes up, it tells how many liters, all that. But how do we titrate it? Do we have a pulse oximeter on our finger and see once it gets back to 98 or something like that, we stop the oxygen? How should we use it? The oxygen cylinder.
Well, the disclaimer again, I'll start saying that if somebody needs oxygen, they should be in hospital. They will need continuous monitoring. They should have a nurse who can keep an eye on them all the time. They should have round-the-clock medical sort of attendance, doctors able to attend. Once somebody requiring oxygen in terms of COVID, the situation can deteriorate really fast. They may require intubation at any time, all kind of things comes. The randomness, random nature of the COVID really makes it difficult to predict. So my strong advice is somebody requiring oxygen, don't think you can just stay at home. The oxygen cylinder, whatever you have, that is only until you get a bed in the hospital. That is the first and foremost thing you must understand. It is absolutely random nature of the COVID makes it really difficult. People can sort of develop severe hypoxia within minutes, from the minute of they're requiring oxygen. So you've got to be careful. And then to answer your question, obviously you need continuous monitoring of saturations, and then you titrate to oxygen saturation. So your guide is symptoms of the patient as well as the oxygen saturations.
So at what time, suppose one decides to home quarantine, symptoms are very mild at the moment, but at what time we are monitoring with, say, the pulse oximeter at home? When should we think that we definitely need the hospital bed? Is it 94, 95, 93?
Rather than one-off number, it is the trend what you need to look at.
Yeah.
Let's say repeatedly over a period of 3-4 hours, every time it is coming 94, persistently 94 or persistently going down. So the trend is more important rather than as one-off value. And then also the symptoms as well. You will know your body, you get more tired and more breathless. So that's the guidance.
Next question. As dentists, we work in aerosol environment. What are the chances of being affected after taking precautions?
don't know answer. It's as I said, the masks seem to be the key bit. Mask and not touching your face and regular hand washing. And then your chances getting from the patients is, very, very low. I wouldn't say no, never is never. But yeah.
Yes.
I think we got a very good, a lot of information how to manage this if we happen to get it, even with medical help, like he said. So I think we will conclude the meeting now. I would say I would like to thank Dr. Srikanth Chukkambotla for kindly agreeing and using his precious time to enlighten us, share his experience with us, and giving a lot of information. Yes, Suresh, please go on.
Dr. Vijay. Yeah, people says that BCG, people who took BCG vaccine has got some kind of protection against COVID-19. Is it true?
Srikanth, do you have any information about this?
Again, as I said, I read a lot of, quite a few papers from the immunology side, but again, that seemed to be the work in progress. There isn't any definite or proven answer. The uncertainty is whether in each country they have like different mutations of this virus. In each country, why people are, populations are acting differently in terms of infection rate or in terms of mortality. These questions are still yet to be answered. There's no sort of clear explanation for all these things.
Okay.
Right, Srikanth, a lot of those messages I find is everyone is thanking you immensely. So thank you very much indeed for agreeing to speak to us, to our dental fraternity. Certainly it is very useful. I have to vouch for that prone position. My relatives who have used this, they repeatedly told me that the prone position was extremely useful for them. So thanks a lot for helping
Thanks
us.
for giving me this opportunity, Vijay. Thank you very much. And thanks for attending it as well. I hope everybody stays safe and, they're sort of prepared and not get it. But even if you get it, hopefully this talk will be helpful for you to fight.
Thank you very much. And thank you very much to everyone for attending as well.
I'll forward the presentation and the WHO guidelines for home isolation. And then if you want, you can forward that to anybody.
Certainly. Please do. And I'll forward it to my friends.
That's great. Thank you very much, Vijay. Thank you.
Thank you. Thank you all.